So we'll now go into more detail on that first core element, which is leadership commitment. For each of the core elements, we provide a number of concrete examples, and those have been prioritized. So priority examples, the most important examples, and then additional examples. So priority examples for leadership commitment include providing sepsis program leaders with sufficient dedicated time to manage the program and participate in performance evaluation and improvement activities. So essentially saying that their leadership's role in that sepsis program is part of their sort of job description, and they have dedicated time to carrying out those activities. The next is providing resources, things like data analytics, information technology support to operate the program effectively, ensuring that relevant staff from key support departments and groups have sufficient time to contribute to sepsis activities, appointing a senior leader to serve as an executive sponsor for the sepsis program, to meet with that program and ensure that the program has the resources and support to accomplish that mission. Examples of senior leaders that could serve in that role include chief clinical officer, chief medical officer, or chief nursing officer. And then finally, communicating to the hospital staff that sepsis is an institutional priority. Next slide. Additional examples to show leadership commitment include communicating how the hospital is addressing sepsis, both to staff and to patients and families, having regular meetings between the leaders of the sepsis program to assess the resources needed to accomplish the hospital's goal for sepsis activities and outcomes, integrating sepsis activities into other quality improvement and patient safety efforts, such as emergency department triage, antimicrobial stewardship, transitions of care, and the CMS SEP1 reporting, and tying incentives to achievement of targets for sepsis care and/or outcomes, essentially incentivizing hospital staff to work towards those goals. Additional examples including sepsis program-related duties in job description for program leaders and key support staff, supporting the training and education for program leaders and key support staff, supporting internal training and education, and then supporting participation in regional, national, and international sepsis quality improvement collaboratives and initiatives. So these are concrete examples, again, that hospitals can look at in that self-assessment tool to say, are we doing these things? Are there important things that we're not doing that we could be doing to improve our institutional response to sepsis? Final slide we have to share is that uptake of the sepsis core elements will be tracked via the annual NHSN survey, just as they were for the antimicrobial stewardship. There were 4 questions that were included in the NHSN survey earlier this year, and additional questions will be added to the next survey, which will go out in January 2024, to evaluate uptake of the complete core elements.
So at Michigan, like other hospitals, we had focused on improving our sepsis care with multiple quality improvement projects going on. I had been involved at prior organizations setting up sepsis programs, and I knew that we were missing some of the foundational pieces to improve our sepsis outcomes. And that's the leadership commitment that Hallie just talked about, that sepsis needs to be managed early and aggressively, and it needs to be an organizational priority. So we started with creating the why and met with executive leadership to promote and ask for sepsis to be a priority for the organization. We shared our performance and how it matched up with other academic medical centers and hospitals, and how our current performance could impact the organization as well as our patients. At Michigan Medicine, at that point in time, our average compliance with the CMS SEP1 bundle was 37%. And we continue to be, well, now we're above 50% compliance, but we continue to be around 50% compliance. National average, 60%, with top decile greater than 80%. And you can get this information on Hospital Compare. We also looked at our mortality index, and it was 1.22. And so that's an observed versus expected. And so greater than 1 is not where you want to be. And we were ranked 15th out of 20 hospitals that were in the top 20 performing hospitals in the US News and World Report related to sepsis mortality. And that's not where we wanted to be. And in 2019, sepsis was not an organizational priority. We had quality improvement teams in the emergency department and inpatient, as well as in transitions between inpatient and outpatient to help with early identification and timely interventions. But it wasn't enough. So our first step was to, so you can go on to the next slide, was to make sepsis an organizational priority. So we gathered our data with included the additional information that I shared on the previous slide. And it was really important to show the links between how sepsis was impacting other indicators the hospital was focusing on. So why should the executives worry about this? So we made the case outlining that sepsis diagnosis was our highest volume of admitting diagnosis after live births. Sepsis was the #1 cause of mortality at Michigan Medicine. And our mortality performance, we know, are part of many programs that the hospital cares about, value-based purchasing, Leapfrog, and CMS star rating. Sepsis was also our leading DRG for readmission, and they had long lengths of stay. And we know with our data that when we provided the SEP1 bundle or the evidence-based practice appropriately, both mortality and length of stay were decreased. So in presenting all of that information, we successfully were able to have sepsis be an organizational priority for the next fiscal year. And it continues to be. We chose first to have our bundle performance be the focus. And so you can see here, we outlined that we wanted our bundle performance to be greater than 55%. When something's a priority, we know it gets more focused. It potentially gets more appropriate resources to support it, and leaders will be held accountable to reach those established goals. It also fit well into our organizational priority of becoming a high reliable organization. And as a high reliable organization, our goal is to reliably provide evidence-based sepsis care to all patients with sepsis. Next step was to get an executive sponsor. In the quality world, it's become clear to improve the potential of success, you need an executive sponsor for projects and programs. This was demonstrated through multiple national IHI initiatives, as well as here in Michigan through the Michigan Keystone work. That executive sponsor increases stakeholder engagement, reduces resistance, helps overcome barriers, and improves the overall program outcomes. And as part of our journey in HRO, as we made requests to executive teams, et cetera, we needed to place those requests into an SBAR. And you can see that displayed on the right side of the screen. And it outlined what our situation was, which is similar to the information, the why, as well as then what's the background and our assessment of where we're at, as well as our ask or our recommendation. And in the recommendation, it outlines the role of the executive sponsor. So be a resource to the sepsis committee and sepsis coordinators, serve as a link to senior management and the strategic aims of the organization, provide resources and overcome barriers on behalf of the team, and provide accountability for the teams and review the team's progress on a regular basis. At the time, we also were requesting a sepsis coordinator, but if you look at the timing, we had entered COVID. And so we had some delays and we had to economically recover from the loss of revenue during COVID. So we were not able to, at that point in time, to get a sepsis coordinator. But in the organization, in the adult hospitals, it continued, sepsis mortality was added as a priority along with the SEP1 performance. And it became an enterprise priority as well. So beyond just the adult hospitals. So go ahead to the next slide. The third step was to create that sepsis program. Moving from quality improvement projects to a program and ensuring we had the necessary resources. So we know that sepsis is not going away. It's not time limited like quality improvement programs often are. And we looked at other successful clinical programs like stroke and trauma and modeled after that. So go on to the next slide. So why did we need a sepsis program? This was the messaging to our leadership. Sorry, lights went out. Sepsis is our highest volume DRG. Sepsis is the largest driver of inpatient mortality. Observed sepsis mortality, length of stay, and readmission rates are above the expected rates, so our ODEs were greater than 1. In using our own data, our risk-adjusted data, it supported that bundle compliance reduced both mortality and length of stay. We had no clear defined clinical owners or operational owners of sepsis care. We knew in our organization sepsis recognition was poor. We were not treating sepsis as the medical emergency that it is, and the general knowledge of the sepsis bundle was poor. So again, we put an SBAR together to request the different components of a sepsis program, and it was beyond just the sepsis coordinator that we were requesting right during COVID. So the data we supplied, you can see here identified on the screen, looking at if we were compliant with SEP 1 or non-compliant, what was the difference in outcomes of interest, length of stay, ICU length of stay, and mortality rate. And you can see, I'll highlight that our length of stay was about 5 days less when we were compliant with our sepsis bundle, the evidence-based care. And you can also see ICU mortality was, or length of stay was less, as well as overall hospital mortality. So we partnered with finance to create a return on investment. Important to be able to do that. Why am I going to give you more positions? What is it going to get for me? I mean, that's the language that in organizations we need to speak. And so we did a pretty conservative estimate, and the outcome of interest that we used for the ROI was length of stay. So we looked at severe sepsis and septic shock populations for over 3 years, and compared to the length of stay when they were compliant with not compliant, as you can see on the graph, and the compliant patients averaged a length of stay of 5.2 days less than the non-compliance. And then we defined the variable cost per patient, a very conservative variable cost, and multiplied that by the number of encounters by the variable cost per day to come up with the dollars saved if we reduced length of stay by 1 day, by 2 days, or decreased it to the length of stay that we achieved when we were SEP 1 compliant. I'm going to turn it over now to Dr. King, and she's going to outline the components of the program and the requests that we made, as well as the sepsis program structure.
Yeah, so now that we had a dollar amounts that as play money to work with, we thought about how do we spend that money? How do we refocus that money into really improving our care? And so we thought about, the size of our institution. We thought about the number of patients that are presenting to with sepsis to our emergency room versus developing sepsis inpatient. And also acknowledge that, attached to the adult building is this lovely pediatric hospital, as well as women's hospital where, sepsis was occurring as well, and with associated morbid consequences. And so we thought about, okay, who do we need? Who do we need to help improve and maintain and sustain that improvement? So when we thought about staff, I'm going to start there. We really thought about, okay, we originally asked, or were considering asking for 1 sepsis coordinator. We have way too many sepsis patients in our institution for 1 coordinator to do the job. So we actually divided that job into 3. And we located these coordinators geographically. So we have 1 coordinator that's dedicated to our adult emergency room. We have another coordinator who's dedicated to the adult inpatient hospitals across the institution. And then we have a 3rd coordinator that's dedicated to pediatrics and women's hospital. Along with those 3 sepsis coordinators, we needed somebody full-time to kind of keep tabs on everything that was going on. So we developed a position called the sepsis process lead. And this person works along with the sepsis coordinators and has, a sort of an overall picture of what's going on across the institution around sepsis initiatives. We recognize that our computer programs are essential to our functioning in the hospital, and we can make no improvements without somebody in the background fixing the computer to do what we want it to do. And so we actually hired a sepsis, we call it a MyChart builder. MyChart is the University of Michigan's version of Epic, who has 100% dedicated effort to building all of the elements that we see as necessary to run in the background in terms of alert systems, as well as to build things like order sets and smooth the transition from emergency room to inpatient. So we have dedicated effort to our computer programming folks. We also asked for a little bit of an administrative assistant role as well. Now, recognizing that these sepsis coordinators cannot do their job without what we call sepsis champions, or physicians who are paired with the coordinators in order to provide the expertise related to that specific area. So we have dedicated effort given to 4 physicians. One is the medical director, who is partners with the sepsis process lead as somebody who kind of keeps tabs on what's going on across the institution with regards to sepsis initiatives. And then we have dedicated physician champions in MOT, which is our pediatrics area, in OB for our women and children's or women's hospital. And then in the ED, the ED sepsis champion has proven to be crucial in moving our sepsis initiatives forward. We also included unfunded positions or positions that already existed within the hospital institution, and asked for a portion of their effort be dedicated to our sepsis program. So we have both the quality and safety officers for UHCVC, as well as the Women and Children's Hospital, with a portion of their effort to be focused, as well as a clinical quality administrator. And then what is also key is someone to help keep track of all this data. So we have institutional support. So these are, again, positions that already exist within the institution, for whom a portion of their time is dedicated to analyzing and summarizing sepsis data from across the institution. So this is what we found as sort of key people that needed to be involved in order to keep track of what's going on where across the entire institution. Next slide. And where do these people sit? So unfortunately, with an institution as large as University of Michigan and physical separate buildings and separate hospitals, we think about, we are a team that exists across the institution, and through, where these building walls do not form real barriers. So the sepsis coordinator for Women and Children's, for example, indirectly reports to the Women and Children's Quality and Safety Administrator. Within the main hospital, the adult ED and inpatient sepsis coordinators report indirectly up to the adult hospital Quality and Safety Administrator. And within that, the pediatrics and adult champions also sit within those silos. We also have a quality department, and within that quality, the sepsis program sits within the quality department. So all of our direct reporting goes up through the quality department, and ultimately up through hospital administration, and we report, essentially to the board. And so, what does this look like on a practical basis? So our adult sepsis team and our pediatric sepsis teams work literally side by side. They share an office in order to collaborate. And And we have connections to and have sought out the expertise of various groups across the institution. So that includes the Office of Patient Experience, right? The Clinical Intelligence Committee. How do we make sure that our alerts are functioning appropriately? The Health System Command Center, and then with outside organizations that support quality and safety, such as the Michigan Hospital Safety Consortium. We have connections with all of these groups, and we sort of see ourselves as the synthesizers of the information, and we use that to develop our quality initiatives in order to improve our sepsis care. We have monthly meetings with the Sepsis Executive Committee, and that includes surgical leadership, medicine leadership, as well as the chief medical officer. We meet with them on a monthly basis, providing updates with regards to data, new initiatives, as well as discuss barriers that we are encountering to moving our initiatives forward. Their support has been invaluable as we hit roadblocks, as inevitably they have a way around or through or over said roadblocks. We also have an advisory committee that we call ISOM, which is Improving Sepsis Outcomes at Michigan Medicine. And these are key stakeholders and leadership across the institution from varying departments, including people who chair phlebotomy and who chair radiology. And so we have quarterly meetings with the ISOM group, where again, we are able to provide updates and bring barriers and see our way around and through and over those barriers. And as I said, ultimately we report up to the Institutional Clinical Quality Council and through them to the Quality Committee of the Board of the hospital. So what has the leadership commitment meant to us? We've really developed over the last year or so support from the hospital and health system leadership, and the chief medical officer and chief nursing officers have become key colleagues and collaborators in this work. We were able to set sepsis performance as a hospital priority and appoint a senior administrator to serve as the executive sponsor for the program to ensure that we have the resources and support we need. We've created a sepsis program with these resources to accomplish those established goals, including sepsis program leaders and physicians with dedicated time to manage the sepsis program and to participate in sepsis-related performance evaluation and improvement activities. And then we've been provided the resources and support that we need to operate the program effectively, including data analytics and information technology support. As a result of all of these recommendations over the past year or so, we've seen significant improvement in our sepsis performance, particularly in the emergency room. And while we still have lots of opportunities, I believe we have the right structure and support to continue our work.